Thank you guys for having me here and for the pleasure of the podium. I think every time as you go through these lovely perforation talks, it keeps escalating up and up and up with beautiful disasters. So I look forward to sharing some of my own. These are my disclosures. And I will tell you, one of the things that I found the hardest as I was preparing for this talk was getting some good video. So I put out stuff on the SAGE's Master Endoscopy Facebook page, and unfortunately nobody else had these complications either. Not sure I believe that. So we'll show you what I've got and we'll go from there. So similar to Eric's talk earlier, ERCP-related perforations are ridiculously rare, 1% of cases, and the problem is the risk of associated mortality and morbidity when they happen. They carry a significant risk if they're not recognized early and treated appropriately, and thus that delayed patient with sepsis is going to have a much worse outcome than the one that you can recognize on the table. And I think what we all recognize in the endoscopy lab or in the operating room is that something isn't going right about a lot of these cases. And I think that is where we have come up with surgical mechanisms in place, such as a difficult lysis of adhesion. We run the valve afterwards. We prove that we have not created a partial or full thickness defect that we haven't recognized. And I would say that we need to apply the same to our endoscopy cases. So if it's a difficult case, and again, most of these you'd have access to fluoroscopy and you don't get that adjunct into your area. But I think confirming with a contrast injection at that point in time will help you quite a bit. So the recognition in the endoscopy lab at the time of your procedure is your ideal scenario. And I know that hurts a lot of people in the room to hear because it means there's a complication, but we all make them. And that's one of the nice things about these sessions is that you can hear that you're not perfect. The ideal scenario with early diagnosis is a PERC because the contamination is less than in a delayed setting. And the treatment often from an endoscopic perspective becomes a lot higher probability of successful treatment, thus limiting your surgical intervention. After your endoscopy, again, very similar to how you've heard from my colleagues, delayed diagnoses, tachycardia in the recovery room, chest pain, this setting usually more abdominal pain, are things that you would like not to find. You'd like to catch it beforehand, but definitely signs on your CT scan that can be a problem, signs on your chest x-ray in the recovery room that can be a problem, such as free air under the diaphragm, are things you've got to take very seriously. I would say for the post-ERCP perforation, I would still favor the upper GI swallow as the test of choice. I do not think that a negative upper GI, though, rules out that perforation. So you've got to use your clinical suspicion in that setting. And I think a lot of the time we end up going with things like CT scan because that's what we can all get at 2 in the morning. So as you can see on this, and I believe I can use the mouse here. Yes, there we go. Well, there you go. So you've got nice amounts of contrast in the duodenum here. You've got your beautiful stent perforating right through the side wall of the duodenum and a beautiful abscess extravasation of that CT contrast. So these are all things that obviously should put red flags on your radar screen. In terms of looking at risk factors, I think you've seen very similar ideas before, but with regards to ERCP, I'd like to divide them into the patient-related factors, the procedural factors, and then the operator factors. So older age, particularly sphincter of OD dysfunction with your preoperative diagnosis, dilated common bile ducts, papillary stenosis, and altered surgical anatomy. And I'm going to show you a post-Billroth 2 video here in just a few. Procedural factors, the pre-cut sphincterotomy, definitely something that you've got to think of. And thanks to Megan Sippy, she answered my Facebook page with help. So I appreciate these beautiful images. This was a case of a 90-year-old that she had gotten called in on for a duodenal perforation, a type 1 perforation as we go through it, that they were able to use the endoscopic suturing technique to close. Other procedural factors, longer duration, again, obviously a sign of increased work during that specific procedure, a harder case in the first place, dilation of a biliary stricture, and inexperience of your operator. So when we look at locations of our post-ERCP perforation in order of descending severity, and again, I need to thank Eric for the CT images and this lovely graphic of the same. There are really 4 categories of perforation, and I think we'll start with the lateral duodenal wall, but I am going to say that Dr. James Ellesmere here is going to be talking about that next, so I'm going to not spend a huge amount of time focusing on it. So these are often a result of either stent erosion and or pressure of your ERCP scope on that lateral duodenal wall that just gives enough force to apply a perforation to that area. Again, if recognized, these have around a 25 to 30% chance in most series of being managed endoscopically, and I think that number is going up and up. So if you're looking at older literature, these were almost always managed surgically. Newer literature, we're really pushing the limits on what we can do here. The type 2 perforation is the peri-ampullary perforation, so again, often related to that beautiful pre-cut sphincterotomy right at the level of the ampulla. And smaller amounts of extravasation or sealed perforations are often managed conservatively. There have been very few of these that I've seen that have required a surgical operation, kind of on the level of the 90% plus success with endoscopic related things and potentially an IR drain for contamination control. This happens to be a plastic stent in place. There's nothing about using the off-label version of a covered metal stent in this scenario, but generally speaking, the results with the plastic are good and they tend to be less expensive. So I think that's what the majority of people would favor, but up for discussion in the question and answer session later. And I think the important thing to talk about both for the type 2 perforation as well as the type 3 perforation, just like the setting of achalasia where you have a proximal leak in the esophagus, you have to have corrected the downstream obstruction. If you didn't finish your myotomy for the achalasia, that leak will never close. The same is very, very true for your type 2 and your type 3 perforations involving ERCP-related damage. And whether it is a distal common bile duct stone, an ampullary stricture, something that is weird about the anatomy with a large duodenal diverticulum that's causing a lack of drainage of that area, you've got to be able to address that so that you can facilitate the closure of that perforation. Type 3 is a ductal perforation, so very similar to your type 2 category and following almost all of those same principles. It's just higher up into usually the common duct as compared to the pancreatic duct, and not at the level of the ampulla, but very, very similar. Small perforations, often managed well with a stenting mentality, getting that to decompress into the duodenum, facilitating that flow by not having that downstream obstruction. And type 4 is retroperitoneal air. So to me, this is always a result of the endoscopy that you've performed. And the question is this a true perforation or is this a side effect of the use of compressed air? That compressed air can dissect through the walls of the bowel. It can get into the retroperitoneum. And I think in certain clinical contexts, this is not a complication, but more a known side effect of doing this procedure. I think, however, if you look at the top CT image, you would agree that that's a smaller amount of retroperitoneal air. There's no fluid associated with it. There's no stranding, no inflammation, and that looks way less like a formal complication. However, if you get something like this bottom CT scan, the fluid in that retroperitoneum, to me, does not make this a type 4. The fluid in the retroperitoneum, to me, means that you've got either a missed type 1 or a missed type 2 perforation. And that raises my level of suspicion. That fluid in combination with the air makes me a lot more worried about that patient, that they're going to get sick and that they're going to have an ongoing issue if I don't treat them appropriately. So type 4 air only and usually in a clinically stable patient. The treatment basics remain the same. So surgery, endoscopy, any other approach that will come out 20 years from now that we haven't even been able to identify as some new technology. The idea is that you've got to close the hole, you've got to divert those contents, whether it's common bile duct in a type 3, whether it's duodenal in a type 1, and you've got to keep that going through the system without ongoing leak. And you've got to watch for any level of a distal obstruction that's going to impair your healing and put back pressure on that area. And in addition to that, if you have contamination, which is again why the intraoperative recognition is much better in terms of these outcomes, you've got to get source control. And I would highly recommend, if you're going to consider an endoscopic treatment, that for your source control evaluation, you consider something like an interventional radiology guided drain if necessary. I thought this was a great algorithm. Again, we've kind of talked through it in terms of all of the slides thus far, but procedures that are diagnosed with a perforation at that point in time have a much higher chance for being able to be treated appropriately, whether that is the endoscopic clips, whether that is suturing, then the peri-ampullary and bile duct perforations, the type 2s and type 3s. Again, This group used a nasobiliary tube. I personally think that's mean. I'd way rather have my stent internalized. But again, all of these people coming back to the teaching point that as long as your patient is responding and improving, that's a great management. And if not, those worsening signs or symptoms, the free fluid that's not controlled, the sepsis picture that's otherwise unexplained, they need a trip to the operating room despite your best efforts to keep them out of the OR. So when you need an operation, these are often large perforations that you're not able to get adequate control of, or a scenario where you can't treat the distal obstruction. So a patient with a bowel obstruction who has a duodenal perf is going to have a lot of issues, right? We all know that scary duodenal stump blowout from prepping for our oral boards for me many years ago. Worsening pictures, sepsis, tachycardia, white counts going up, belly pains getting worse, all of those ominous signs, the lactic acidosis that you can't explain otherwise, and failure of endoscopic treatments. You know, sometimes you get those stents on there, everything looks beautiful, and all of a sudden your contrast is still extravasating on your post-treatment study. Those are the times when you got to put your ego out of the way and you got to get it done, and you got to get it done right. And if that's a trip to the operating room, that is not a failure. It's the next step in the algorithm. So this is that lovely patient that has the Bill Roth reconstruction. Gorgeous example of a sort of duodenal, but probably really jejunal because of the altered surgical anatomy. An altered surgical anatomy is obviously on the list of things that increases your risk, but that is the hole directly into the peritoneum. The cap is being used to facilitate visualization, facilitate retraction. You can see the clips coming down. You have already actually seen this technique described, starting at the end of the perforation, placing multiple clips in a linear fashion, and then using the through the scope endo loop equivalent to be able to contain these areas together. And this, again, is thanks to Eric. I really appreciate his help with this. Non-surgical management of the type 2 and type 3, again, your peri-ampullary and your ductal leaks are often endoscopic stent placement, and often you will need to consider something like that IR-guided drain or potentially a PTC if you're not able to get it taken care of, but you don't have that rip-roaring area that needs to take you directly to the operating room. So lots of minimally invasive approaches for the addressment of that. And in terms of outcome, you know, as much as I love minimally invasive approaches and as much as I love endoscopic approaches, you have to do what is best for your patient with your hands at that point in time. And there are some patients that you are willing to push the limit on, and there are other patients that can't tolerate a haircut. So you've got to take that into consideration. I thought this data was great because it really distinguishes that type 1, which is the lateral duodenal wall perforation, where about 30% were able to be treated with medical and endoscopic options, versus those type 2 categories where 90% were able to be treated that way and only 7% required surgery. So good literature out there, and again, since that description of those classifications, we've really gotten a lot better at talking about what type of perforation, the size of perforation, and all these things, and kind of helping develop these algorithms. So my take-home message is post-ERCP perforations are not common, 1%, but again, the significant rate of complications, up to a 15% mortality if not recognized and treated appropriately. The treatment really depends on that location of the perforation as well as the degree of contamination. The ideal location for recognition of your perforation is in the operating room or in the GI lab at the time of your scope, and thus your endoscopic management options are available. And I think they're great options, but you want to do those in the right patient population who are your stable patients and your patients who can tolerate that. And again, if you need something else done, go to the operating room. It's not a failure, it's just the next step in your algorithm. And these are all my residents who are learning these great techniques.